Very good morning to all of you. Good morning to all of you. Today's class is on transposition of great vessels. Now, in the previous class, we had also discussed the details of conotruncal anomalies, your understanding of conotruncal anomalies, and a prototype of one of the conotruncal anomalies, that is Fallot's tetralogy. Now, transposition of great vessels is also another example of cono-truncal anomaly. So, to briefly recapitulate, cono-truncal anomalies are related to development of the conal septum, the process of looping, the development of truncal septum, and subsequently development of aortopulmonary septum. So basically it is related to the process of looping and also the development of the various septums, which are all related to the outflow part of the ventricle. Now, in normal hearts, you have a subpulmonary infundibulum present or a conus present. However, there is no subaortic conus and there is aortic mitral continuity because of the absence of subaortic conus. And because of the presence of subpulmonary infundibulum, you have pulmonary tricuspid discontinuity. So, what happened to the subaortic conus? It probably got resorbed. And why did it get resorbed? Because there is the role of neural crest in the migration and resorption of the cardiac cells. So, as regards the conus, you can have four combinations. In a normal heart, you have subpulmonary infundibulum and you have the aortic valve to atrioventricular valve continuity, that is aortic to mitral valve continuity. Now, in detransposition of great arteries, which is what we will be seeing today, you have a subaortic infundibulum and you have pulmonary valve to atrioventricular valve continuity. So, pulmonary valve to mitral valve continuity. In double outlet right ventricle, you have bilateral infundibulum. Therefore, there is no semilunar or arterial valve to atrioventricular valve continuity. In double outlet left ventricle, you have bilateral deficient infundibulum. That means there is bilateral semilunar or bilateral arterial valve to atrioventricular valve continuity. Now, coming to the process of looping, the heart, as you know, is a straight tube. And during the process of development, it loops, it curves to the right. This is known as de-looping, whereby you get right ventricle on the right side and left ventricle on the left side. If for some reason there is L-looping, the heart loops to the left, it is known as L-looping. You will have left ventricle on the right side and right ventricle on the left side. Some people describe looping in terms of chirality, that is a right-handed pattern or a left-handed pattern. In a normal right ventricle, if you put your left hand into the region of the septum, if you put your right hand in the region of the septum, your inflow will come into the atrioventricular valve, and the fingers, that is the thumb, and the fingers will go into the outflow part of the ventricle. However, you can also have, when there is a problem, you can also have a left hand pattern. All cono-truncal anomalies have, majority of them rather, have chromosomal damage which are related to microdeletions in 22q11 chromosome. This particular chromosome and microdeletion interferes with neural crest migration and results in inadequate migration of the cells from the cardiac neural crest. So as a consequence of inadequate migration, you have poor development of the cono-truncal and aortopulmonary septum. Some of the syndromes associated with cono-truncal anomalies and microdeletions of 22q11 are the catch-22 and the charge syndrome. So let us look broadly at the origin of cono-truncal anomalies. So the distal bulbus, the truncus, and the aortic sac. All these form the great arteries and the outflow of the ventricles. Then you have the heart tube and the process of looping, and you have the aortic arches. All of this contributes to the cono-truncal anomalies. So all cono-truncal anomalies have anatomic features in common, that is abnormal development of the conus. And this is largely because of chromosomal damage leading to deletion of 22q11 chromosome, which interferes with neural crest migration. There is inadequate migration, and as a consequence, poor development of aortopulmonary septum, and you get cono-truncal anomalies. Now these are the cono-truncal anomalies. Pathology of Fallow, which we saw last time, AORV, transposition, and truncus. Today we will be dealing with transposition of great vessels. So what is detransposition of great vessels? Here you have the right atrium leading to the right ventricle. The right ventricle leads to the aorta instead of the pulmonary artery, as you would see in a normal heart. The left atrium leads to the left ventricle, which then leads to the pulmonary artery. So there is abnormality in the ventriculo-arterial connection, and this forms the basis of transposition. Now, way back in 1797, it was first identified by Matthew and Bailey, who called it a singular malformation. In 1811, it was also further described by Langstaff. In 1814, John Farr, he coined the term transposition and basically described the origin of great vessels from wrong ventricles, which is the basis of transposition. But then there were other people with different thoughts. 1903, 1924, Gippel and Monckeberg, they believe it is more a question of arterial relationship. In 1939, Harris and Faber described 8 basic types of arterial relationship and ventriculo-arterial connections, which could be either physiological or anatomically corrected. So there are 8 different types according to them. But in 1971, it is Van Praag who said that transposition exclusively means ventriculo-arterial discordance. It doesn't matter about the arterial relationship. When you have ventriculo-arterial discordance, that means the ventricles connected to the wrong great vessels, then you have the condition of transposition, irrespective of how the great vessels are related. So it is defined variously, but the basis is ventricular-arterial connections, arterial relationship, aorta had to be anterior, the infundibular morphology, that is pulmonary valve to mitral valve continuity, and the presence of a subaortic infundibulum. So the most important part is ventriculo-arterial connections, and the rest fall in place. Actually, transposition is derived from the Latin word transporere. You can describe it as complete when both the arterial trunks are placed across the septum, and partial only when aorta is placed across the septum, as you get in double outlet right ventricle. However, which is the most important feature? Discordant ventriculo-arterial connection is the most important feature of transposition. So you have complete transposition or DTGA. You have concordant atrioventricular. That means right atria leads to the right ventricle. Left atrium leads to the left ventricle. Concordant atrioventricular connection and discordant ventriculo-arterial connection. That means the right ventricle is connected to the aorta and the left ventricle is connected to the pulmonary artery. Then you also would have heard of corrected transposition. We will deal with this in the next class. Corrected transposition is when you have atrioventricular and ventriculo-arterial discordance. For example, the right atrium leads to the left ventricle. The left ventricle leads to the pulmonary artery. The left atrium connects to the morphological right ventricle, which connects to the aorta. So here basically the circulation is okay. Two wrongs make a right. The circulation is normal except that the atrioventricular and ventriculo-arterial connections are all discordant. Then the third term you will come across is malposition. Here you have abnormal relationship of great vessels other than transposition. We are not talking about ventriculo-arterial connections here. It is just the relationship between the great vessels. So instead of the aorta being posterior and to the right, pulmonary artery being anterior and to the left, you could have abnormal relationship, but we are not concerned with the ventriculo-arterial connection. So in transposition of great vessels, you have aorta arising from a morphological right ventricle and pulmonary artery from a morphological left ventricle. Now Van Praag uses the terms S, D, D, etc. So TGA, that is transposition of great vessels, can be S, D, D. That means situs solitus of the thoracic and abdominal viscera. That means atria are in their normal position. D loop of the ventricles, that is the right ventricle is on the right side and the left ventricle is on the left side, and D position of the great vessels. That means the aorta is and the pulmonary artery, aorta is to the left and pulmonary artery is to the right. You can also have TGA with SDL, situs solitus of the thoracic and abdominal viscera, including the atrium, D lobe of the ventricles, right ventricle on right side, left ventricle on left side, and the great vessels are again abnormally situated, L position of the great vessels. Then if you have mirror image, you have ILL, L transposition. I is indeterminate, L lobe of the ventricles, that means the right ventricle is on left side, left ventricle is on right side, and L position, that means aorta is to the left and pulmonary artery is to the right. So it is a congenital malformation characterized by origin of the great arterial trunks from morphologically inappropriate ventricles. That is, the aorta and pulmonary artery are misplaced across the ventricular septum. So you have aorta arising from right ventricle and pulmonary artery from the left ventricle. It constitutes about 5 to 7% of all congenital cardiac malformation. The incidence is about 20 to 30 in 100,000 live births. Males are more commonly affected. Extracardiac anomalies are infrequent, less than 10%, and usually not associated with other complex cardiac anomalies. Are there any coexisting factors? Nothing really specific, though they say there is an increased prevalence in diabetic mothers and mothers who had prenatal exposure to sex hormone therapy. There may be an increased chance of transposition of great vessels. So the normal conus is subpulmonic, it is left-sided and anterior. When there is abnormal development, growth and absorption of the infundibulum, as you see in transposition of great arteries, you have a subaortic conus which is right-sided and anterior. So what is the basis of the embryology? It is primarily related to malpositions of the arterial trunk. Now, the outflow, as you know, is formed by the fusion of the bulbotruncal ridges. And instead of forming a spiral septum, they fuse in a straight way. This is the theory of de la Cruz. However, Gore and Edwards believe that there is maldevelopment of the ventricular outflow and differential absorption of the infundibular structure. In a normal embryo, the pulmonary valve moves from a posterior position to become anterior and left, and this becomes related to the normal development of the subpulmonic conus. The aortic valve remains stationary and there is reabsorption of the subaortic conus. In transposition, there is abnormal growth and development of the subaortic conus, absence of growth of the subpulmonic infundibulum. So, discordant ventriculo-arterial connection is the only distinguishing characteristic that defines TGA. And major anatomic, there have been different classifications of TGA. The major one depends on the relationship of the great arteries to each other and or the infundibular morphology. But primarily in TGA, there is subaortic infundibulum, absent subpulmonary infundibulum, and therefore there is fibrous continuity between the mitral valve and the pulmonary valve. Now this is a normal heart, the aorta, the aortic valve and the mitral valve. So you see aortic, mitral, fibrous continuity, there is absence of the subpulmonary infundibulum. However, in transposition, you see there is pulmonary valve, two mitral valve, this is the left ventricle, fibrous continuity. The aortic valve is a little, you don't see it here, is it? It's a little superior and anterior. There are subtypes of transposition. You can have transposition with intact ventricular septum, transpositions with ventricular septal defect, transposition with a ventricular septal defect, left ventricular outflow tract obstruction, then transposition with ventricular septal defect and pulmonary vascular obstructive disease. What about the orientation of great vessels? In about majority of the patients, the aorta is anterior and to the right of the pulmonary artery. Sometimes aorta can be anterior and pulmonary artery may be posterior. Or the aorta may be anterior to the left of the pulmonary artery, that is LTGA. So this is the external view of a case of transposition. See, the great vessels are lying parallel to each other instead of the usual way you see normal hearts where they are twisted around each other. So here you see the aorta is anterior and to the left, pulmonary artery is posterior and to the right. You have the right atrium, right atrial appendage. This would be a morphological right ventricle which leads to the aorta. So here is another example, right atrium, aorta and pulmonary artery. Their relationship is almost what it would be normally, except that their positions are reversed. In a normal heart, this would be pulmonary artery and this would be the aorta. In transposition, they have exchanged positions across the ventricular septum. Another interesting finding in transposition of great arteries is juxtaposition of atrial appendage. Both atrial appendages sometimes come to lie together on the left bord towards the left side of the heart. You have the aorta which is anterior and to the right, pulmonary artery is posterior and to the left, and the right atrial appendage has come from behind to lie adjacent to the left atrial appendage. This is known as juxtaposition. Not uncommonly seen with transposition of great vessels. So, coming to the anatomy, the right atrium is usually normal. You may have a PFO, patent foramen ovale, or an ASD in 5%, and the SA node and the AV node are normal. The right ventricle shows normal inflow and sinus portion. Central fibrous body is small. The atrioventricular and membranous septum are small. The ventricular septum, instead of being a curved structure, is straight. The RVOT and the LVOT are parallel to each other. So, This is the basic anatomy of transposition of great vessels. So ventricular septum is straight, ventricular outflows are parallel, the aorta has a muscular infundibulum. However, pulmonary valve is not wedged deeply between tricuspid valve and mitral valve, as normally an aorta would be. Pulmonary valve to mitral valve, there is fibrous continuity. So there are three main groups: transposition of great vessels with intact septum, transposition with VSD, and transposition with LVOT obstruction. So here you see the left ventricular outflow. This is the left atrium leading to the left ventricle, left ventricular outflow leading to the pulmonary artery. And here you see mitral valve to pulmonary valve fibrous continuity. On the right side, you have the tricuspid valve, the right ventricle. This is the trabeculoseptomarginalis. The medial papillary muscle is attached here, and the right ventricle leads to the aorta. Why is it aorta? Because you can see coronary ostia here, and subsequently it also gives rise to the arch vessels. Now, if in transposition you can often get VSD. The VSD can be mainly perimembranous. It can be muscular, subarterial, or malalignment type of VSD. So this is the right ventricle, the aorta, and the pulmonary artery. So mainly you get a perimembranous defect. You can have muscular defects which can be inlet, trabecular, outlet, or you can even have a subarterial defect. So here you have a perimembranous VSD. This is the morphological right ventricle, tricuspid valve, the right ventricle leading to the aorta with the coronary artery here. As seen from this is again another view, VSD here, RVOT, the tricuspid valve, and right ventricle leading to the aortic valve and aorta. Another view of the right ventricle. Here is a VSD. It is an inlet muscular VSD, and the right ventricle leads to the aorta. You can see the coronary ostia here. This is the medial papillary muscle of the tricuspid valve. On the left side, here you have the left ventricle leading to the pulmonary artery, and you have a muscular VSD here, mitral valve to pulmonary valve, fibrous continuity. Here you have right ventricle with a subarterial VSD. So this VSD is just beneath the aortic valve. So you saw perimembranous VSD, you saw muscular VSD. Now this is an example of subarterial VSD, the right ventricular outflow, and here you have the VSD just sitting beneath the aortic valve. This is the tricuspid valve leaflet. As seen from the left side, this is the subarterial VSD sitting just beneath the pulmonary valve, left ventricular outflow, and mitral valve to pulmonary valve, fibrous continuity. The other important aspect of TGA is many cases have LVOT obstruction. This may be with or without a VSD. So it can be subvalvular or very rarely valvular obstruction. The subvalvular obstruction can be a fixed type of obstruction or a dynamic type of obstruction. So the dynamic type is more common. and it is often due to bulge of the ventricular septum. Here you see the left ventricular outflow leading to the pulmonary valve, pulmonary to mitral valve continuity, and here in the region of the interventricular septum, you see a fibrous bulge with marked fibrous ridges. So this forms kind of a narrow tunnel, an obstructive kind of LVOT obstruction. Here you see a small VSD again on the left side, and it is surrounded by multiple fibrous ridges. This will again cause a dynamic type of obstruction. You can get tissue tags or accessory valvular tissue as you see here. This is the LVOT pulmonary valve. So you get these accessory valvular tissue protruding through the VSD or even with surrounding tissue tags. So this causes an obstruction, but it is largely a fixed type of obstruction. Again, another bulge here in the region of the membranous septum, and this is again a fixed type of obstruction that you see here. Other forms of obstruction, you can get deviation of the outlet septum. This is seen from the right side. So the outlet septum gets deviated into the right ventricular outflow, and you get associated pulmonary valve with overriding VSD and cooptation of the aorta because it causes obstruction to the right ventricular outflow. Now this is almost akin to a fallow, but with reversal of the great vessels. So the outlet septum can be pushed into the right side, or it can be pushed into the left ventricle, and whichever side it is pushed into, there will be obstruction of the right ventricle or the left ventricle. Associated anomalies. Here you have, this is an operated case, and here you have a common AV canal kind of defect, and some kind of switch operation has been done here. Here there has been a large ASD which has been patched up. Other associated anomalies, you can have tricuspid valve anomalies with anomalous caudal attachment to the VSD, redundant valvular tissue protruding through the VSD into the LVOT causing obstruction. You saw some pictures of that. An inlet type of VSD with the tricuspid annulus overriding it or straddling it with straddling of the tensor apparatus. Abnormalities of the mitral valve have also been noted when you may get abnormal papillary muscles, chordae, or redundant tissue tags. You can get ASDs like this, fibriform type of ASDs, large ASD in a case of transposition of great vessels. Ductus connecting the aorta to the pulmonary artery is a very important lifeline in transposition of great vessels. The other important part of transposition is the coronary artery anatomy. Now, usually you have two aortic sinuses of Valsalva, which are the coronary ostia, which face two pulmonary arteries, and these give rise to the two coronary arteries. So, two aortic sinuses facing two pulmonary artery sinuses. These aortic sinuses are posterior, and it is from these that you have two coronary arteries arising. You have the aorta anterior, pulmonary artery posterior, and you have the left coronary artery with the LAD and the left circumflex coming out here. So you have two sinuses of origin and three major branches of coronary artery. Right coronary artery, left circumflex and LAD. Sometimes you get proximal intramural course of coronary artery. The media of the aortic and coronary artery are together. They don't have a separate adventitia. And you may get artery to the sinus node, commissural mismatch, etc. This is important to note the coronary artery anatomy because one of the major procedures for correction of transposition is the switch operation. So in 1983, Leiden proposed classification that remains the most widely accepted. In this position, you make a small person stand in the in the anterior aortic sinus facing the pulmonary artery. If he spreads his hand out, the aortic sinus on the right side will be the right sinus. The aortic sinus on the left side will be the left sinus. So with this classification, the commonest coronary artery pattern is denoted as 1LCX. That means from the first sinus, right sinus, you will have the left main coronary and the circumflex, and from the second sinus, you will have the right coronary artery. The strength of this classification is that it is simple and it describes more than 95% of coronary pattern. It is widely accepted by the surgical community. It has limitations because you are unable to define epicardial or intramural course of coronary arteries. And you can't define additional arteries like arteries to sinus node and rare instances of coronary artery originating from the non-facing sinuses. This classification serves 95% of the TGAs. So then Yacoub further classified it into type A, type B, type C, type D, type E. Type A, left coronary from the left sinus, right coronary from right sinus. This is the standard. Type B, you have a single coronary artery. Type C, you have two paracommissural ostia. More likely, you are likely to get intramural coronary arteries. Type D is the right coronary and circumflex arise from the right ostium, the LAD from the left ostium. Type E is right coronary and LAD from the left ostium, circumflex from the right ostium. This is another classification, Wernovsky type of classification. This is the most common type, the left coronary arising from the first sinus and the right coronary from the second sinus. And these are all different variations with lesser and lesser percentages. So the usual pattern is seen in almost 67% cases. Circumflex from right coronary artery in about 16% of cases, and the rest are all very infrequent. So this is an echo cut to show you the left ventricle leading to the pulmonary artery. This is the subaortic infundibular septum. Now, what is the physiology in transposition of great vessels? There is deficient oxygen supply to the tissue. Therefore, there is increased RV and LV workload. The circulation are in parallel to each other. And intercirculation mixing is important, and it depends on whether there are intracardiac shunts like PFO, ASD or VSD, or extracardiac shunts like patent ductus or bronchopulmonary collaterals. Effective pulmonary blood flow, effective systemic blood flow are all important. The net right to left shunting, the net left to right shunting. All this depends upon the intercirculation mixing. Now the role of bronchopulmonary collaterals. Less than 30% of infants with 2 years. This is significant because it leads to a free communication in the pulmonary bed. However, it accelerates the process of pulmonary vascular disease. In the fetal life, this physiology is compatible with survival. The fetus generally has a normal gestational development. At birth, the right atrial pressure is high. The foramen ovale remains patent, so you may have bidirectional shunting. Ductus also remains patent, therefore you have shunt from the aorta to pulmonary artery. The problem is when you have an intact atrial septum, there will be severe hypoxemia. When the ductus closes, you will have severe hypoxemia. Now, transposition with intact ventricular septum or a small VSD leads to increased pulmonary blood flow, very small intracardiac shunting. Therefore, these babies will have cyanosis from the first day of life. If they have a large PDA, there will be milder cyanosis, but they will have tachypnea. If the TGA has a large VSD, it will still relate to increased pulmonary blood flow and increased cardiac shunting. Congestive cardiac failure takes about 2 to 6 weeks to develop. There is mild cyanosis. If there is transposition with LVOT obstruction, you will have decreased pulmonary blood flow and then there will be cyanosis right from birth. So at birth, the baby with TGA is usually stable. The problem arises if the ductus arteriosus begins to close or if the foramen ovale becomes restrictive, then you have worsening cyanosis and respiratory distress. To keep the ductus patent, drugs like prostaglandin E1 may be used so that the ductus reopens. If the oxygen levels are still very low after prostaglandin, or if the infant is very ill, then temporary palliative measures may be achieved by performing balloon septostomy. That means you make a large opening in the foramen ovale to ease shunting of the blood flow. When the infant is about 1 week old, then arterial switch operation can be considered, connecting the aorta to the left ventricle and the pulmonary artery to the right ventricle as you would get in a normal heart. The procedure also involves reconnecting the coronary artery. Foramen ovale is closed and the ductus is also closed off. Before arterial switch came into existence, a repair type of operation was done which was known as Senning or mustard arterial switch procedures. It was done a few months after birth. Here a baffle was created within the heart and it was at the level of the atria to direct blood from the right atrium to the left side and from the left atrium to the right side. So it effectively corrected the circulation, but the right ventricle becomes the systemic ventricles, which is not ideal. The right ventricle is not designed to withstand the workload involved. The right ventricle is not a workhorse like the left ventricle. So the long-term prognosis for mustard or Senning arterial switch is not very good as an arterial switch. There were arrhythmias, sudden deaths, right ventricular failure, and survival, 90% survival for at least 10 years and 80% for at least 20 years, but invariably leading to sudden death. Then these patients were also at a risk of developing pulmonary vein stenosis because of the atrial backfill. The prognosis for arterial switch, this is known as Jattin's operation, was good. In a study of about 1,000 patients, 88% survived for 10 years, and no further deaths between 10 to 15 years after surgery were noted. Conditions like arrhythmias, heart blocks, etc., which were seen with mustard and senning, are rare. However, you may get dysfunction in coronary arteries, some mild left ventricular dysfunction, pulmonary valve and or aortic valve dysfunction in about 5 to 20% of patients. So the preferred method of surgical repair is the Jattin arterial switch operation, usually performed in the first few weeks of life. This approach is superior to the atrial switch operation. Another important aspect of transposition is the conduction system. Usually the SA node and the AV nodes are normal. If there is an inlet type of VSD, you may have conduction defects. One has to be careful of damage to the SA node arteries because this may be present in the interatrial groove, have an intramyocardial course, and also cause supraventricular dysarrhythmias. So damage to the SA node was more often seen after the atrial switch or septectomy because of the intramyocardial course in the anterosuperior rim of the fossa ovalis of the artery to the SA node. This can cause acute necrosis, infarction of the SA node, hemorrhage, and edema. And if the patient survives, it can lead to fibrosis of the SA node. So with this, we come to the end of the transposition of the great vessel.